Hey everyone, it's Adam Farkas back with you here at CECO 2018, and I have Dr. Ben Casella with me again, and we're going to switch gears and talk about a topic that is very serious. It's not about trends this time, it's about narcotics. And treating your patients who might have an addiction. You are actually here at CECO and you have a really cool lecture about narcotic prescribing.
I do.
Now, this is a huge topic that, frankly, most people haven't really talked about before, right? This is not your typical optometric conference lecture.
No, it's not. And the reason that it's not is because most of abuse and addiction that happens with narcotics comes from chronic use.
Sure.
And we as optometrists are primary doctors for the human eye, and so we treat primary care issues. Acute eye pain is one of those, and acute eye pain typically would not need a narcotic for more than 2 or 3 days. That would typically be seen as inappropriate. However, on the front lines of eye care and on the front lines of healthcare in general, we are uniquely poised to recognize signs and symptoms of abuse, and it is an absolute epidemic. My lecture, which I'm going to give in a few minutes upstairs, is going to attempt to hammer home just how big this is. In the year 2012, there were over 250 million prescriptions dispensed legally for opioids in the US. And when you couple that against the fact that there's only 300 million people in the US, almost every man, woman, and child United States citizen had his or her own bottle of pills for a year.
Right, and I think that's a really huge issue, and it's a huge issue even among clinicians. I worked in an addiction clinic for a while, and obviously confidentiality is very important, and when you work there, you're starting to see people from the community that you know, and you would never have guessed. And so I think people need to realize this isn't just, it's not a stereotypical patient that you're going to see. These are people from all walks of life.
Yeah, it does not discriminate.
It really does not.
And that includes doctors.
Absolutely,
yeah.
And it's becoming a bigger and bigger problem. So I think it's important for everyone to know what to do. Not only identify the person, but what do you do? How do you actually help?
Shut the door. You try to emphasize that you and the patient are a team. You're not judging the patient. You're going to scare somebody off if you just yell at him or her.
Sure.
And it takes a team approach to initiate help. You ask if you can speak to next of kin, you ask if you can speak to loved ones, and you communicate with the patient's primary care physician, and if he or she doesn't have one, you ensure that he or she gets one.
Right. And are there any resources, I guess it varies state by state, right, where you can direct people to get help?
Absolutely. The Centers for Disease Control and Prevention, under the direction of the Department of Health and Human Services, has put out a dozen or so guidelines, and those guidelines are readily accessible on cdc.gov, and it is a stepwise approach, and they're very specific, and they are evidence-based.
Right. Actual science.
Actual
Imagine
science.
that. So we will actually have a link to that right on ODwire right underneath this video. So Ben, thanks for the help today.
Thank you.
All right.